Hello, I'm Umair Khalid. I'm one of the social media editors at Jack Cardiovascular Interventions, and it is my great pleasure to welcome Dr. Robert Smith. Thank you, Dr. Smith, for joining today.
Oh, it was my pleasure. Good to see you this morning.
Thank you. So today we are excited to feature your TCT LBCT presentation titled One-Year Outcomes of Transcatheter H2H Repair in Anatomically Complex Degenerative Mitral Regurgitation Patients in our social media section. Could you please begin by providing our audience with a definition of anatomically complex degenerative mitral regurgitation? And if you could please share the number of such patients included in your analysis.
Sure. So first off, thanks for having us. It's my pleasure to represent the investigators of this trial. The patients in the Class 2D registry were deemed ineligible for the actual randomized trial. But these are the types of cases that we considered kind of yellow zone cases, according to that paper by Scott Lim. You know, in the trial, in the randomized trial, they were all kind of the green zone patients. So now we're thinking outside of the box, the yellow zone patients. And most importantly, these are patients who largely had 2 or more independent significant jets, had bileaflet multi-scallop prolapse, could have had a small mitral valve orifice area, large flail widths and large flail gaps, and significant jets in the commissural areas. All told, we treated about 98 patients in the Class 2D registry. And these characteristics that these patients had were ones that we really often, come up against in clinical practice, but have not been really covered under the MitraClip IFU, which notes that the safety and efficacy of the MitraClip therapy and those anatomic conditions has not been well established. And therefore, we felt that this fit better into a registry. There's been a lot of experience with these patients. And so we thought, hey, this is a great opportunity to explore them, to study them, and to report on it.
Thank you, Dr. Smith, for your response. You briefly touched upon the MitraClip. If you could briefly describe why Pascal transcatheter system specifically could be potentially suitable for this type of complex anatomy?
Sure. There's several design features of the Pascal system that are helpful in treating some of these anatomically complex DMR patients. And a lot of that we found out during the extent of this registry. So first off, the independent leaflet capture and optimization capability was new to us at the time when this device came out. And it really helped, particularly in a lot of these difficult anatomic features, the opportunities to really try and optimize the leaflet capture, which we had not had before. There's a single row of retention elements, and you can think about in these complex anatomies, there's a lot of grasping that may take place, a lot of, resituating the device. And so that in and of itself may reduce some of the trauma to the leaflet and preserve that leaflet integrity so you can have multiple opportunities to grab the tissue. There's also a flexible nitinol stent material that distributes the stress on the leaflets. Some of these valves had a lot of different tensions on them, and so we thought that could be a potential improvement on the device. There's the thing I really like about it is the way that it elongates so that you can navigate through some complex anatomy, particularly subvalvular apparatus where there's a lot of cords. And as we're working up into the commissures, that can be quite an issue. And so being able to get yourself out of trouble safely so that you can reposition your device and go back to try to attack that anatomy was really important. And lastly, they came up with a new delivery system, the precision delivery system, while we were in the midst of the trial. And that really helped with a lot of the maneuverability. So it was a real step up in the delivery system. So multiple features that I think helped along with these anatomic issues that we were being challenged with.
This is very helpful. Thank you so much for clarifying, Dr. Smith. My next question is specifically regarding the procedure itself. So regarding the intricate anatomical considerations, could you please elaborate on the procedural times, the average number of tears per patient, and did any patients, require any, urgent bailout surgical, urgent surgical bailout?
Okay. So, kind of one at a time. So the procedures were longer, as you would expect. This is complex anatomy. So the average procedural time was about 124 minutes, just a little over, and the median time was 111 minutes. And while that seems long for straightforward anatomy, for complex anatomy, it's not out of what we would expect. On top of which, all the investigators were learning a brand new device. right? So this was new to them. Now, it may not have been new to them by the time they got to the registry, but it was new to many people. And for many investigators, the registry was their first opportunity to use the device. The mean number of clips, devices placed was about 1.6. Now, that's telling, but at the same time, there were a diffuse amount of anatomies involved here. So we can envision those with multi-scallop prolapse, multiple jets required more devices. And then those with the really small area, we were just trying to very, very carefully place one device in a strategic position. And then the last question was, did anyone require surgery? There was one patient who underwent surgical mitral valve surgery for what was during the case found to be mitral stenosis and grasping the leaflets. And so what happened is they found an excessively high gradient of around 6 millimeters of mercury with a very small valve area, about 2.2. And so the device was removed. It was elected to remove the device, abort the procedure, and that patient then went on to have surgery, not in an emergent fashion.
Sounds good. Thank you, Dr. Smith. And finally, if you could share the outcomes with the audience, including the clinical, echocardiographic, and quality of life outcomes briefly with the audience.
For sure. And this is the exciting part of it, right? Which is, what did this all culminate to? So the results of the PASCAL system demonstrated, first off, high survival and freedom from heart failure hospitalization. There was significant and sustained mitral regurgitation with 93% of those patients in the registry sustaining MR to less than 2+. And the mean mitral valve gradients remained under 5 millimeters of mercury. Echocardiographic improvements were also noted, and most impressively was left ventricular reverse remodeling, which we expected to see to a degree, but it really confirmed that the MR reduction was real. And so it was a real bonus to also see that. Overall, there were significant sustained improvements in quality of life. The KCCQ scores improved and the NYHA scores reduced, and that stayed that way throughout the 1 year afterwards. So overall, the PASCAL system did a really good job of improving MR reduction, maintaining this MR reduction with LV remodeling, and improving quality of life outcomes. So overall, the outcomes in the registry are good, but it's really notable to remember that these are yellow light kind of an anatomic features, and those can have an impact on outcomes. And so we see really good outcomes, but when we look at the randomized control trial, we see those are green light patients. And I think it's important to remember, as both of these trials are being presented, that these are different anatomic classes. So we almost really expect to see a much better improvement in MR reduction in those green light patients than the yellow light patients. But overall, these outcomes are really helpful, and particularly helpful for the clinicians as they are treating patients with anatomic features that they don't get to decide who comes into your office, but now they can have much more meaningful conversations with the patients on what to expect from the outcomes of these interventions.
Terrific. This is great to hear. Thank you again, Dr. Smith, for sharing these insightful results with us, and congratulations on your work.
Oh, we really appreciate being able to share.